In our previous portion of this lecture, we were going over cranial nerves. I neglected an aspect of cranial nerve 3, oculomotor. While testing oculomotor, in addition to doing extrinsic eye muscles and checking eye movement, you should also grab a pen light and shine it carefully into the pupil. Start from the side, move your way in, and monitor pupillary constriction. If you're already in a bright environment, it's not really going to change. But if you're in the dark, then that pupil should constrict, and so should the opposite pupil. They should have consensual pupillary constriction, both at the same time. Okay, we'll move on to our chapter 16 content, the spinal cord and spinal nerves. So spinal nerves are peripheral nervous system. The spinal cord is actually the central nervous system. We'll talk about the gross anatomy of the spinal cord meninges, the sectional anatomy of the spinal cord, the spinal nerves, and reflexes. You're going to get your first circuit. So when we say circuit, we're going to say the first neuron cell body is here, the axon goes there, then there's going to be another neuron cell body, another axon, and maybe there's 3, and there's another neuron cell body and another axon. And where does that go? That's what I mean by a circuit. And so reflexes are your simplest circuits. So they're a really good one to start with if we're going to learn any circuits. We're not learning a ton of circuits because this is just A&P 1, not an advanced neuroscience class, so you're not learning every circuit. Finally, we'll finish with some development of the spinal cord, and that's going to be very closely related to the embryology that we covered already. So the spinal cord is a link between the brain and the rest of the body. It's going to carry all of your pathways. Now remember, I mentioned no matter what order I teach this to you in, there's going to be stuff you have to fill in later. So next week we'll talk about the sensory and motor pathways, and then you'll come back to this idea of the cross-sectional anatomy of the spinal cord. And of course, responsible for reflexes, which is our quickest reactions to a stimulus. What this means is that a reflex, it needs to go to the central nervous system, but it only needs to go to your spinal cord in order for you to have a reaction. And since it only needs to go to the spinal cord and not all the way up to the brain, it's going to save us a lot of time. If you've ever grabbed a hot plate and withdrawn your hand before you even felt the pain, that's because that reflex was acting before it had time to make it to your brain, which is ideal if we're trying to save our tissue from a burn, attack, whatever it is. So spinal cord anatomy, there's going to be gross anatomy of just the entire spinal cord, not cross-sectional. And luckily, these regions should look really, really familiar. You're going to have a cervical spinal cord, a thoracic spinal cord, lumbar, sacral, and coccygeal spinal cord. Now, we'll start with just our general anatomy over here. And we've got up here cervical, let me get off of this thing that I'm holding right now. So cervical spinal cord here, C1 to C8. We'll address that C8 when we get to spinal nerves a little bit more clearly. How many cervical vertebrae do you have? 7. So that C8 is going to change things up a little bit. But you'll still have T1 through T12, L1 through L5, S1 through S5, and then just one coccygeal. Now here's what's going on though. If you look up close here, that spinal cord is actually terminating right around L1. So let's say just inferior to L1, that's where you're going to find the termination of the spinal cord. When we say that you have an L2, L3, L4, etc., those are spinal nerves. Those are spinal nerves that are exiting the spinal column at the corresponding vertebra. But the spinal cord has actually ended. It got thinner and thinner, and then it ended right around here at L1. So there's some specific anatomy here at the termination of the spinal cord. And you can see my cursor on the recording. I know you can't see the cursor right now, so I'll kind of do this twice, one for the recording, one for just everybody to see this visually. So the spinal cord is here, and it's terminating here around L1 at what we call the conus medullaris. So as it narrows and narrows and narrows, it narrows into a little cone, and we call that cone the conus medullaris. And from the end of the conus medullaris, there is a single ligament called the filum terminale. And now, of course, you still have many, many spinal nerves. You don't have a complete spinal cord, but you have spinal nerves that continue to emerge at different vertebral levels. It appears like a horse's tail. So if we were to pull this out of the vertebral column, it would look like a horse's tail. We call that the cauda equina. So that collection of spinal nerves within the spinal column below the termination of the spinal cord is called the cauda equina. So I'll show you up here. Here's the spinal cord getting narrower and narrower, and then this portion right here is the conus medullaris. Just that last terminating cone part. And then if you look carefully, here's kind of part of the horse's tail, so to speak. If you follow that conus medullaris, there's your phylum terminale. That actually connects to the coccyx, your coccyx bone, and that's going to anchor your spinal cord in place. So you can do a cartwheel and your spinal cord's not just going to join it. Yeah, that's right. What was the phylum terminale again? It's a ligament that connects the conus medullaris to the coccyx and anchors the spinal cord in place so that you're not distracted. Phylum terminale is the ligament. Conus medullaris is the termination of the spinal cord. The rest of these spinal nerves that are still in the vertebral column, collectively they look like a horse's tail, and that's the cauda equina. Like a little avatar tail thing. Perfect. Okay. What else? We will see, especially on the next page in much more detail, that there's something called a cervical enlargement and a lumbar enlargement. And what that means is part of your spinal cord gets thicker for a little while, and then it thins again, and then in the lumbar region it thickens again, and then it gets thin again. So one thing you are tasked with doing, let me grab this thing real quick. You will be tasked with recognizing visually the different levels of the spinal cord. So I want you to think about that spinal cord logistically. You're going to have spinal nerves emerging at every vertebral level, right? And you're going to have pathways for sensory and motor ascending and descending in the spinal cord. As things exit, we're going to innervate that thing, right? So what we're going to find is that once we've gone past the arm, we're not going to carry pathways for the arm anymore, right? We already innervated it. All that information came and went from and to the brain. So once we're below the level of that arm, there's not going to be any more information for the arm, right? And then for each segment of the trunk, we're going to get rid of all of that information. Then we'll get to that lumbar segment and we'll innervate our legs, right? So as we're going down the spinal column or spinal cord, generally the rule is smaller and smaller, right? We'll need less and less room because we're carrying less and less information. So it's pretty literal. So generally from cervical to sacral spinal cord levels, you get smaller and smaller. Aside from that cervical enlargement and the lumbar enlargement. But one other thing you can see is that there's less and less white matter. So this is one of those things that's out of order. I haven't taught you what white matter versus gray matter is yet. Gray matter means that it's mostly cell bodies. White matter means it's mostly axons. The axon appearance, they're myelinated. Myelin appears white in gross anatomy. So even if you don't stain it, you don't do anything, you just cut into it, it appears physically gray versus physically white. So physically gray means there's not a lot of myelin there. And so that's going to be mostly cell bodies. And then white means there's myelin there. Can we shut that door? They're doing mock interviews next door. They're going to get distracted by us, if anything. Okay, so gray means mostly cell bodies. White means pathways. It means axons. It means that's where information is traveling, right? Is that clear for everybody? Okay. So you'll see mostly less and less white matter as you go down these structures. because there's no more pathways. There's no more axons because the axons for your arm already left. The axons for your trunk already left, right? As you move down the body plan. I think there's going to be better places for me to talk about that butterfly shape aside from this. Yeah, let's talk about that butterfly shape a little bit more later. So yes, you do have to recognize these different levels. So again, you'll have spinal nerves emerging at every level of the vertebral column. Between each vertebrae, you'll have spinal nerves. So even though your termination of the spinal cord is in the lumbar region, you still have spinal nerves emerging below that, and we'll call those the lumbar, sacral, and coccygeal nerves. Is that making sense for everyone? Okay. Here's why there's 8 cervical. And I got to go over for Bob for this one. Maybe I'll pull him over. So you're going to start with spinal nerve C1. And that's going to emerge superior to C1. And then you're going to have spinal nerve 2, and that's going to emerge superior to cervical vertebra 2. And so on, 3, 4, 5, 6, 7. So here you're at C7 spinal nerve, and it's emerging superior to, C7. C8 emerges below C7. From here on out, every spinal nerve emerges inferior to the corresponding vertebra. So this was, let's say, T1, 2, 3, 4, 5. That's T5. Sure enough. Then the one inferior to that is spinal nerve T7. Cervical C1 through C7 will emerge superior to the corresponding cervical vertebra. C8 will emerge inferior to corresponding cervical vertebra, and the rest of them, thoracic, lumbar, sacral, coccygeal, will emerge inferior to the corresponding vertebra. And that's really it. That's just something that keeps you from looking like an idiot one day, right? So they could say, okay, I have a L1 to L2 impingement, and you would know that that corresponding nerve is which one? Lumbar, which one? 1 or 2? 2, yes. Yep. Lumbar 1. Sorry, I had to think about it for a second. L1. That would be an L1 because it's inferior at that stage. Okay. Going to zoom in here a little bit. The next slide's going to actually be better for the meninges. But let's start looking. Let's see, what else do I want to say here? Start looking at the shape of this butterfly. The gray matter is like the butterfly wings. This direction is dorsal. Dorsal, ventral. I'm going to have to zoom back out so you can see it. So this way, oh my gosh, why did I do that? Is dorsal. This way is ventral. So you're going to have the skinnier wing of the butterfly be dorsal, and the fatter wing of the butterfly is going to be ventral. You're going to have 3 layers of meninges surrounding your brain and spinal cord, and luckily it's pretty much the same in your brain as it is in your spinal cord. You're going to go from superficial to deep with these meninges. So what meninges do is they help stabilize, they support, and you're going to have the flow of cerebrospinal fluid deep to one of these levels. So most superficially for your meninges, you have dura mater. It translates to tough mother. That is one tough mother. And it's true, it is a tough mother. We can actually, when we do our sheep brain dissection, we will feel the sheep dura mater, and it is quite strong. You're gonna have to use scissors to cut it. You won't be able to tear it apart. And human dura mater is even thicker than sheep dura mater, so it's going to be pretty impressive and protective. And you're going to have some structures in the brain associated with that dura mater. Deeper to that, you'll have the arachnoid mater. There will be a thin membrane, and deep to that, the arachnoids, the subarachnoid space is going to be this cobwebby layer, which is where we got that name arachnoid. It looks like a spider got in there and built some cobwebs over your brain. And even deeper, adhere to the surface of the CNS is the pia mater. It would actually be very difficult to remove the pia mater without also scraping some of that nervous tissue off. So that, in addition to having the layers of the meninges, you'll have spaces associated with those meninges, really important, clinically significant spaces for you. So here's the dura mater. Superficial to the dura, we call that the epidural space. Sounds familiar, right? If you had an epidural during childbirth, they injected some stuff into this epidural space and allowed it to simply diffuse over and numb you. Sound familiar for anyone? Okay. You're like, no. Does it mean not familiar or just don't want it? They didn't give you one. That's unfortunate. 9 minutes. It's a world record. Yeah, so there's your epidural space. You're going to see that clinically a few times in a few contexts. We're going to see it around your brain as well, that epidural space. You can have an epidural hematoma, which means you can bleed into that epidural space. Right? These are all important terms for you. Subdural would be deep to the dura mater, but superficial to that arachnoid membrane. And then subarachnoid means you're bleeding probably into your nervous tissue, which is going to have really different implications, right? For where bleeds are, for where hematomas are, for what those clinical outcomes are. Okay, so far so good? Keep going. So those different parts of our spinal cord, they all have different names. That dorsal part of the butterfly wings, we call that the dorsal gray horn. You can also call it the posterior gray horn. Dorsal and posterior are interchangeable terms. So that's why it says posterior horn up there, but I'm saying dorsal. I find in neuroscience we tend to use ventral dorsal a little bit more often than we use posterior anterior. So we really do need to be very comfortable using those interchangeably at this phase. So dorsal gray horn. And then up here, we're going to call this the ventral gray horn. And then you have your white matter portions. And this terminology is going to get a little annoying. What we're going to see is about a dozen different ways to say there's cell bodies there, and a dozen different ways to say there's axons there. And I've already given you your first one. I've already told you that gray matter has cell bodies and white matter has axons, right? Now, funiculus is one of our words that means axons are there. What I actually recommend in your notes is that you start making a list of things that mean cell bodies and things that mean axons, because there's actually a lot of them. So funiculus, and if you go to other sources, you may see this phrased fasciculus. And that means the same thing. It means there are axons traveling there. It's part of a pathway. It's white matter. Fasciculus. What's up? Yeah, a little bit. In the periphery, not in the central nervous system. We're not going to see that epineurium or perineurium in the CNS.
So far for axons versus cells, for axons we have
And the white matter.
White matter. Okay.
Yeah. So on that list so far for axons, we do have white matter, we do have funiculus, we do have fasciculus. And like I said, this is my baby. I've been in neuroscience for a really, really long time. I tend to use interchangeable terms interchangeably as a bad habit. So I'm going to go back and forth between fasciculus and funiculus like it doesn't mean anything. Like they mean the same thing. Okay. So generally, you have a posterior or dorsal funiculus, lateral funiculus, and ventral funiculus. So behind this butterfly wing is the dorsal funiculus, lateral is the lateral, and then right next to that ventral gray horn, you'll have your ventral funiculus. Doing okay? You look like you have a question. Who has questions? We're just doing anatomy right now. We haven't done any function. Sure, absolutely. I'm going to zoom in, and again, once I zoom in, you can't see my cursor anymore. So dorsal gray horn with dorsal funiculus, ventral gray horn with ventral funiculus, and we're actually going to see in some levels of the spinal cord, but not all, a lateral gray horn, and this is a poor illustration of a lateral gray horn, but we'll worry about that later, and a lateral funiculus. This brings us to our next slide. Okay. Generally, you're going to have a rule of thumb for your nervous system and I'm going to teach you this rule of thumb and it's going to make your life a little bit easier, if you can remember it. We're going to put it into motor memory to help you remember it. Right now, you're going to tap the back of your head and you're going to shake one of your hands in front of you. What I mean by this, keep doing this while I talk. What I mean by this is that dorsal generally is going to correspond with sensory, so you can feel that on the back of your head, right? That's because sensory is dorsal. And ventral generally is going to be motor. You can see your hand moving in front of you. That's a motor activity, and it's ventral. It's in front of you. Okay, you can stop now. Motor is ventral. Motor is ventral, sensory is dorsal. As a rule of thumb, it's not a perfect rule. Nothing in the brain is always going to be 100% true. If there's ever a standardized test question that says, and one of the options is always or never, if it's talking about the brain, it's not that one. You can pretty much count on that for standardized tests. I don't think I have any test questions that look like that, unfortunately. It's not going to help you. Laterally, what we're going to have in the lateral gray horn is autonomic. And again, we're not learning autonomic until week 10. So we kind of have to go after autonomic back to this concept of the lateral gray horn when we're done with that. Okay, so again, something to just visualize very specifically. In the spinal cord, the gray matter is centrally located and the white matter is radiating out from that superficially. So in the spinal cord, you have gray matter deep, white matter superficial. It's going to be the opposite in the brain, even though that is all central nervous system. Good? Let's see. What else? I think I missed the anterior white commissure. Notice that you have a sulcus and a fissure in the posterior and anterior portions of the spinal cord respectively. There's a little bit of white matter connecting the two ventral funiculi up here, and that's called the anterior white commissure or commissure. Why is this important? When we learn our pathways, which is part of next week, each of these funiculi is going to have a corresponding sensory or motor pathway. Each of these gray horns is going to have a corresponding sensory or motor function. And the general rule is going to be this stuff's going to be sensory and this stuff's going to be motor, although that's not going to be perfect. It's going to be 75%. All right, questions before we move into spinal nerve anatomy? We just did spinal cord anatomy. Oh yeah, does anybody want to know what's up with that cervical enlargement and lumbar enlargement now that we have some vocab for it? Let's talk about those enlargements. So, it's going to be the lower part of the cervical spinal cord, and it's going to be the lumbar region. what is there? So like embryology style, I'm kind of sitting out like a doll. This is how your body plan works in embryology. So what's up here, your cervical region, and what's here with your lumbar region? Arms and legs. Your cervical enlargement is enlarged because you're going to have more cell bodies there for the neurons that go out to your arms. And the lumbar region is going to be because there's going to be more cell bodies there associated with your legs. Whereas innervating your trunk, we're going to see is very easy and lightweight track. So it's going to be thinned when it's just your trunk or when it's just your neck. Okay. We've covered this already with your spinal nerves in the periphery. You'll have an endoneurium around individual neuron axons, perineurium around fascicles, and epineurium around the entire spinal nerve. But wait, there's more. This image is great for roots versus rami. Roots versus rami. Now, we know that this is dorsal. Let me get my thing going. We're zoomed in. Oh, wait, I can't get my thing going. You know where dorsal is. You know where ventral is. You know that this is mostly sensory and this is mostly motor. So what you have here, immediately connected to that dorsal great horn, immediately connected to that ventral great horn, those are roots. So the roots are like underground, right? So think of the roots of a tree, they're underground. Think of this is the ground right here. So this is the root for the dorsal great horn. This is the root for the ventral great horn. So we would call that the dorsal root and the ventral root. And now you already know the rule of thumb. So if I'm just asking what is that dorsal root going to carry? Is it going to be sensory, motor, or both? What are you going to guess based on your rule of thumb? Sensory. That dorsal root carries only sensory information. So our direction of information flow is actually going to be in to that dorsal root. We're going to have afferents to the dorsal root. And then if you had to guess that ventral root, sensory, motor, both, which one? Which one? Motor. There we go. Motor. So the ventral root's going to carry only motor information, at least for now. We'll add autonomics later. When those two meet up, they're going to form a nerve. And so now you have afferents and efferents traveling within the same bundled structure. So is that going to be sensory, motor, or both? If it's a nerve, both. So by the time you get to here, where the dorsal and ventral root will come together, you will have the nerve, and that carries both sensory and motor information. What we see next is the nerve splits. It branches. So the nerve now branches. So now we're above ground. That nerve was like a tree trunk. And now that tree trunk is going to branch. We'll call everything else a branch. Yep. This is the branch. This is called the Dorsal Ramus. It's a branch, right? Oh yeah, sorry, you can't see it. This is the Dorsal Ramus. It's a branch. And this one is the Ventral Ramus. This one's the Ventral Ramus. So this one, Dorsal Ramus, this one, especially in the trunk region, it's going to the postural muscles. It's going straight back to the postural muscles. The anterior or ventral rami, if we're in the trunk, that's going to be an intercostal nerve. And anywhere else, it's going to participate in a network of nerves that we call a plexus. So we'll be learning the plexuses. Okay, so a ramus, is it going to carry sensory, motor, or both? Both. It's just a branch of the tree. So we'll have sensory and motor from the intrinsic back muscles at this level. And then over here, we'll have sensory and motor from anterior body, arms, legs, if it's part of a plexus, or intercostals if it's trunk. Good? So roots versus rami versus nerves, what type of information do they carry? Yes, is it sensory, is it motor, is it both? Know that for each of those things. Now with our ventral rami, for each of our spinal nerves, there's going to be a clear segment of skin that is innervated, sensory innervation. It's very clearly demarcated if it's a somatosensory nerve. And that is what we call the dermatomes. We call these dermatomes. What this gives us, if somebody has a paresthesia, if they have numbness, if they have tingling over a very specific segment of skin, we can trace that back to their spinal cord, to their spinal column. Maybe they have a herniated or bulging disc that is impinging that specific spinal nerve level, right? So that gives you a lot clinically. I'm not going to hold you to a whole lot of this, but what we are going to do is watch an absolutely horrible rap. So I'm going to pause this and we're going to go watch the dermatome rap. Dermatome rap has a lot of clinical significance, and it's also clinically accurate with arguably one exception. He does claim that L1 is where we have our fun, but our genitals are actually innervated by a sacral nerve. If you want to note there, it's actually S3 for genitalia. So depending on where you have fun, I suppose. So those important things that you can use as major milestones is, like we said, T4 is the nipples, T10 is umbilical. The C6 gun is really convenient. I've actually had that impingement before. I've had the C6 impingement and had my C6 gun go like numb and paresthesia. It was great. So they're all some valid things. I would recommend learning a couple of major landmarks and just going medial or lateral or superior or inferior to that one to recognize the rest of them. And again, the clinical significance is that if there's anesthesia or pain in a region, it could indicate specific levels of potential spinal nerve damage. And it's also going to give us a little bit of referred pain patterns. Referred pain patterns are going to be a little weird. What we're going to find is that the visceral innervation, it's not going to be as straightforward as the somatic innervation. Somatic, we've got dermatomes. It's very specific and localized, right? You get cut in the body wall, you can point to where you were cut. It's not hard. But with visceral innervation, those nerves tend to ascend or descend before meeting up with the spinal nerve, and that's actually going to give us some of our referred pain patterns. So a really common one, for example, is appendicitis pain commonly refers to the periumbilical region in T10 because that appendix nerve, the nerve from the appendix, tends to ascend to that T10 spinal nerve and meet up with it, typically. Not everybody's going to have that typical pathway, but that is our typical pathway for that. Okay, so a plexus. Remember, these are ventral rami. Ventral rami participate in either a nerve plexus or they're an intercostal. So you're going to be tasked with recognizing the major plexuses, the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus, and compare and contrast that with intercostal nerves, which are the really easy ones. So intercostal nerves are very literal. It just means for each thoracic level, for most of your thoracic level, you're going to have a dorsal ramus that just follows along a costal, a rib, and that's it. It doesn't do any bobbing or weaving. It doesn't do anything confusing. It's just an intercostal nerve. Life is easy here. In addition to being able to visually recognize each of the plexuses, I'm going to tell you about significant nerves from that level, and you should be able to identify the significant, important nerves from that level that I will make very clear to you. So here is your cervical plexus. You'll see it's got portions from C1 through C5. The ventral rami, again, are participating in this mess of nerves right here. What you see with your plexus is they'll join together and then they will split again, right? Here's C3 and 4 and 5, and they all have contributions towards each other. And then they all split again, right? The most clinically significant nerve that I want you to know about from the cervical plexus is the phrenic nerve. This is the phrenic nerve. It's contributed to by C3, C4, and C5. There's a saying in emergency medicine. Do you know it? Anyone? Does anybody know the saying for the phrenic nerve? No? Okay, see, 3, 4, 5 keeps the diaphragm alive. So the phrenic nerve is going to go and innervate your respiratory diaphragm. And that's going to keep you breathing. So if somebody's got a cervical spine injury, it's concerning for a number of reasons. One of those reasons is that they could lose innervation to their respiratory diaphragm and have respiratory complications. So that's why you're learning about the phrenic nerve. So again, this is the phrenic nerve right here. It's not to say that these are not also clinically significant nerves, but that's the one I want you to know. So for cervical plexus, again, visually identify the cervical plexus, visually identify the phrenic nerve emerging from it. The brachial plexus, like you said in the wrap, is kind of tough, so let's break it on down with some nasty stuff. 5 major nerves coming this that I want you to know about. Again, probably 20 major nerves coming from this. We're learning 5. This is the brachial plexus. You'll see contribution from C5 through T1. And here's some good news for you. There's this image of the brachial plexus. There's also this image of the nerves that are emerging from the brachial plexus. Now, the good thing about the thing that's emerging, the nerves that emerge from this, is some of them are going to be regionally named. You're going to have a radial nerve, you're going to have an ulnar nerve. And that's going to help you a little bit. You also have an axillary nerve. You know where your axilla is. So that's 3 down, if I ask you on that picture. I do generally prefer on lab practicals to allow you to visualize what it's going to and what it's serving, rather than something like this where you're literally just counting to tell me which nerve it is, right? Because in real life, people do have some individual variations on blood vessels and nerves and things like that. So I don't like, as a practice, making you just count and say, okay, the 3rd one down, that's going to be our axillary nerve. That doesn't really help you in real life. What helps you is knowing where it's going. So again, I know you won't be able to see my cursor for a minute, so I'll do this twice. So you'll have your axillary nerve, and you'll see that actually emerging around to that sort of deltoid area. And then you'll have your musculocutaneous nerve, really superficial here. Your musculocutaneous nerve, it actually serves your biceps brachii muscle, is its only motor. It's mostly sensory to that surface of your arm. So there's musculocutaneous. And then a better place for me to ask you about radial and ulnar and median nerves would be down here. So there's your radius, and not surprisingly, this is going to be your radial nerve, and it's going to go actually to the dorsal aspect of your forearm. The median nerve is right in the middle, and then the ulnar nerve is on the ulnar side of the hand. So let me repeat that where people can actually see me.
Musculocutaneous nerve, very superficial over that biceps brachii. And then median nerve, right down that midline there. Ulnar nerve on the ulnar side. And then radial nerve, let me make sure there's superficial nerves of radial nerve. Right there, wrapping around to the back.
So again, there's radial nerve right there. So this image versus this image, if I'm asking you individual nerves, I would prefer to ask you on this. If I'm just asking you to identify the brachial plexus, I'd use that. To the brachium. Yep. Honestly, there are nerves in here that do not do the brachium. The long thoracic nerve is going to be down here. But yeah, for the most part, that's accurate. And I don't think we're doing RTDCT, roots, trunks, divisions, cords, terminal branches. In a like med school level, you would be expected to know all of the roots, trunks, divisions, cords, terminal branches, what contributes to it, what it splits into, all of the ins and outs, the anterior parts, the posterior parts, the superior parts, the inferior parts. We're not doing that. You're welcome. Yeah, you're welcome. Lumbar plexus. Now, some people will say collectively lumbosacral plexus, and that's valid as well, but we are going to separate the lumbar and sacral plexuses in this class. So here's just the lumbar plexus. Two very significant nerves emerging from the lumbar plexus, the femoral nerve and the obturator nerve. So again, your femoral nerve, it's coming around here. Almost all of this is femoral nerve, branches of femoral nerve right here. It's going to innervate the entire anterior portion of your leg. And the obturator nerve is going through your obturator foramen, which is going to help you identify it here. And that's actually going to come and innervate this medial compartment where your adductors are. So again, lumbar plexus has femoral and obturator, whereas sacral plexus is going to have the sciatic nerve. So what we're going to see is the sciatic nerve is gigantic. It's about as thick as my thumb. And that's going to do the entire posterior leg. It's actually going to split into tibial and common fibular divisions. So even though it's posterior, this fibular is actually going to go anterior again. And here's the clinical significance there. Sometimes people are going to clutch the front of their leg and say, I've got sciatica. Does that person have sciatica? No, they have a femoral nerve impingement, right? That's painful. Sciatica is painful. Femoral nerve impingement is painful. It doesn't make it less painful. It just means they're clutching the wrong compartment and they've got the wrong nerve identified. Yes.
The femoral, I think it's the femoral nerve that passes through the hole in the.
Yeah. Yeah, the adductor hiatus. That's correct. Let me go back here. Nope. Nope. We're not going that far down. Okay, and it's 150, and that's a good stopping point before we get to reflexes. Any question before I stop the recording?